All right, everyone. It is 7 o'clock. Let's go ahead and get started. Welcome to the last session of the Teach for LA Spring 2022 Virtual Workshop Series. Thank you so much for being here. I know many of you have been in sessions throughout the day. I've been in a lot of them too, and they've been amazing. So thank you for hanging on. This is going to be a really informative and moving session, and I'm very proud to have Misti Lindquist here. Let me just quickly introduce myself and go over some housekeeping. My name is Dr. Marini Smith, and I am a faculty member at West Los Angeles College in Culver City. I teach child development and education courses. I've been in higher ed for about 8 years. I love what I do, and I'm so excited to be a part of the Teach for LA Regional Collaborative. You all are very fortunate. And I know having this virtual space makes it a lot easier, especially at 7 p.m., right? When a lot of us are taking care of kids or family members, or we're winding down, we're, hanging out on the couch, or we have our dinner right now. So thank you again for choosing to be here with us this evening. So this session is being recorded. The recordings will be available. Give us a couple of days. The recordings will be available on the Teach for LA YouTube page, and I will put that in the chat. You will be able to see not only the sessions from this virtual workshop series, but you should be able to access previous sessions as well, which is super exciting. It'll be a great resource for all of you to be able to look back on previous presentations. I will be kind of just introducing Misti and giving her the floor, but I will be here. Renee, Marshall, and I will be here to monitor the chat, to help facilitate question and answer, and just to kind of monitor the engagement and let us know if you have any questions, and we'll do our best to answer your questions and to make sure that you're getting everything out of the session that you bargained for and more. Certificates as well. Those of you who are interested in getting certificates of participation, those will also be sent out via email after tomorrow's closing session. So probably give us till Friday the latest, Renee?
Sorry, I hope you don't mind, but
no, please.
I'm going to do them for the whole conference. So if everybody can just give me till Monday.
Perfect.
I just need a couple days because since we have the conference, then on Thursday I go back to back for meetings.
Yep.
And so just to kind of give me a little chat to catch up. And it's great because everybody can fill out the conference survey at the end of the conference, and that's where you put exactly how you want your name to be on the certificate, and you vouch that you attended appropriately and whatnot, because we always have to make sure that it matches and whatnot. So we will send that out. I'll send that out tomorrow. I'll send it out at first at the closing ceremonies or closing session. And then I will send it out right after, and then I'll just rolling out the certificates as I get a chance to get to all of them.
Perfect. Thank you. So let me just share a little bit of background with how I know Misti. So Misti is a certified child life specialist, and I actually met her about 5 years ago now in the hospital when my son was hospitalized. I have, my son is now 8. He was about 3 at the time. He was in Kaiser Hospital due to severe epilepsy. And I just remember Misti and her warmth and her calming presence, because it was a very scary time for my family to have a young child. At the time, we did not know what his diagnosis was. We just knew that he was in a very difficult place and he was suffering, and we didn't understand why. And to be honest with you, even though I teach child development and education, I really didn't fully understand or grasp what a child life specialist did or what their role was. And I saw firsthand how Misti came into our room multiple times. She checked on us. She checked on my son. So that's her priority, and made sure that he had what he needed, different toys, books. Kaiser had a wonderful, a variety of ways to help children who are in a hospital situation, who are probably scared, who are probably questioning, they don't know what's happening to them, to have things to calm them, to keep their mind off of things, to give them some enjoyment. So we had things like animals, like a dog that came by the room that the children could pet, and we had a wonderful violinist who came by. But Misty kind of facilitated all of these different comforts, and really her focus was on making sure that my child was well cared for, not just in the medical sense, but in the social emotional sense. And so that was really, really powerful. And even back then, in talking to Misty, I said, hey, would you be interested in maybe talking to some of my students about what you do? Because this is really amazing. And so she was able to come to West LA College pre-pandemic. It was about, I think it was in 2018 when she came and spoke to one of my classes. It was actually 2 classes combined. So it was a packed classroom, and she did an amazing presentation about what it is to be a child life specialist. And I was so moved, and I learned a lot as well, but I was so inspired. It takes a special person, and you will see when she talks about it, it takes a really special person to choose this line of work. It's like nothing else that you've ever heard of. But I was so inspired because so many of our students had never necessarily considered this as a career. And so many of our students after that presentation said, this is something that I want to do. This is something that I am thinking of pursuing now, because they learned about this new world and this new way of caring and helping and making a difference in the life of a child and their family. So I just wanted to give you kind of like my little personal anecdote on how I met Misty. So I'm going to give you her formal bio, and then I'll turn it over to her to share with you about her role. So Misty is a certified child life specialist, and she's worked in a hospital setting for over 16 years. She currently holds a BA in child development, a minor in psychology, and a master's in human behavior. Misty started her career at Children's Hospital Los Angeles, where she worked for 5 years supporting patients and families throughout the hospital setting. Misty moved across the street to Kaiser Permanente Los Angeles Medical Center, where she worked in the pediatric intensive care unit while cross-covering in pediatrics and supporting children of adult patients in oncology and intensive care unit. Misty has a passion for advocating, supporting, and guiding children and families through their hospital experience, creating a sense of normalcy through transition of illness. Misty is honored when she can support families during end of life as she assists children and families in their understanding of grief and loss. Misty now serves as an adjunct professor in the Behavior and Applied Sciences Department at Azusa Pacific University. So now, without further ado, I'm going to turn it over to Misty to tell you all about what it's like to be a child life specialist and all that it has to offer.
Thank you so much, Marini. It's amazing when you can connect with families and see them away from the hospital and have follow-up and see how they're doing and see how the kids are doing and how everyone's adjusting, and that doesn't happen all the time. So it was very, very much God sent that Marina and I met, and that I get to continue to share with her students about child life. So let me share my screen so we can jump in, and Marini will interrupt if there's any questions or any thing that you guys want to know addition, please. I am an open book, and I enjoy so much sharing about child life because it is the most amazing job that people don't know about that you can do with child development degree or psychology. Okay. All right, so let's get started. Okay, so we're going to start by going over some of the objectives that I want to get through with all of you, and that is one, defining what child life services are. A lot of people haven't heard of child life unless one, they've been in the hospital with a family member or they themselves have been in the hospital. It's not something that is known as much. It is getting more known because a lot more people are finding out about child life. I want to discuss what the child life specialist role is as part of the multidisciplinary team, because you work with a variety of professions that are across the span of working in the hospital, including administration. And then also understand how children cope and adjust to hospitalization, which is a big component of what child life specialists do. And what Marini had said, creating that normalization, because children, the first thing that they want to be are children. The way they want to be seen is as children, not sick children. And that's oftentimes when people are like, oh, how do you do that? Oh, that's so sad. But as child life specialists, we see children as children before we see children as sick children. So the role of a child life specialist. We are going to talk about the description of what child life does, education and background. I'll go over some interventions that I do and things that we do as child life specialists. I'll talk about preparation and support, and then jump into grief and bereavement. As a child life specialist, our number one goal is to reduce the impact of stressful and traumatic experiences that affect children in the hospital, their development, their health, and our goal is to create and enhance their well-being in the hospital. Oftentimes, when you're working with children in the hospital, the doctors, the nurses, their goal is to fix it. They try to make it better. As child life specialists, we understand that we may not fix what's going on physically. We may not fix what's going on emotionally, but we want to help them through it and get through the process of being in the hospital, which is a completely different environment. It's very different even on how you parent a child that is in the hospital. In addition to what we do working with patients and parents, we also help parents to parent hospitalized children, because oftentimes parents' first thing that they want to do is give their child everything because they're sick, because everyone wants to make children feel better. As a child life specialist, what we want to do is help them cope and adjust, not necessarily make them feel better. Although that is a great perk when we're able to do that. Like Marini had discussed, I have my bachelor's degree. All child life specialists have a degree, whether it's psychology, child development, something related to working with children. When you get your degree in child development, it really helps you to identify where children are, not just chronologically, but also psychologically. So not just focusing on children's age, because when you're in the hospital, that could be very different. Most children, just like we as adults, regress when they're in the hospital because we're scared, we're not sure what's going on or what's happening. And I don't necessarily mean regress to the point where children will go, a 9-year-old will go back into diapers, but emotionally, children regress, just as we do. We have to do 120 to 200 hours of practicum, which is student field work. That's where you get introduced to child life and learn about what a child life specialist does. And then after that, you go and jump into a 600-hour internship, which is non-paid. Doing an internship, that is really the bulk of learning to be a child life specialist, learning how to talk to children, learning how to prepare children, learning how to be 100% honest, even when it may be hurtful for the parent and also for the child that we are servicing. Internships are typically done after your or during your bachelor's. You can do it. If for some reason you graduate with your bachelor's and you decide, oh, I want to be a child life specialist, then you'll probably have to jump into a master's program for child life. Because in that master's program, you're going to get the opportunity to have internships, because most hospitals want you to be affiliated with the school in order to do an internship. Not all hospitals, but mostly because of insurance. Okay. When helping to, some of the interventions that we do, the role that we have is presented here, helping children cope and adjust. And coping and adjusting is meeting children where they are and how they understand, and helping them to not see and understand things through misconceptions, but through what it really is. So really helping them identify how to acknowledge the feelings that they have, acknowledge that it's okay to be scared, and helping them to navigate that. Oftentimes, especially the teenagers, they'll put on a front like, I'm good, and they won't express how they feel. And some people will take that for face value. But as a child life specialist, we dig a little bit deeper and we don't look at just the face. We look at not only verbal expressions, but those nonverbal expressions, which can tell you just as much as profound information as a child that is going to tell you what's happening and what's going on. We prepare children for tests and procedures. We do procedural support. And what that means is when a child is having a procedure, say an IV placement or a PICC line placement, which is a special line that children have to have medication, child life specialists will prepare them, explaining what it's going to feel like, the medicines that they'll have to help them sleep if they do have medicines, what that PICC line is for, using materials to help introduce the PICC line, and helping children to not only see it, but able to manipulate. A big part of what we do is therapeutic play as well. In therapeutic play, that is an opportunity to express feelings without having to use words. And children learn best through play. They express themselves through play. When they're stressed or overwhelmed, they may not have the language to say that, but they can express it through play, which is a big misconception about child life specialists, because a lot of people see us as play ladies, or all we do is play all day. But child life specialists play with a purpose, and that purpose is to find out how children are coping and adjusting and what they understand, because that will play out in their play. Medical play, that is an opportunity for children to manipulate materials that we use, to poke dolls, and to express that fear that they may be, or the anger that they feel from having so many procedures done, can also come out through medical play. We do grief and bereavement support during end of life, helping to understand what death is, using the words, concrete, honest language, which is difficult for parents to do. Distraction is a technique that we do if a child's having a procedure. Say something that we feel is really simple is having tape removed. For children, it's not simple. It's the hardest thing that they have to experience in the hospital is honestly the tape removal, because it's been on for several days and it gets really, really sticky. So as a child life specialist, we'll come in with different distraction tools and techniques, whether it's playing I Spy to distract them from what's going on their bodies and get them engaged in play. And they don't even realize things are happening to them because we engage them in play, or using different materials. I have some in my granddaughter's playroom, but I didn't bring them in here, but things that they can hold on to, like squeeze balls or spinning lights, anything that's going to get them distracted from what's happening. Big part is advocacy. Oftentimes, doctors and nurses, even parents, think that children can handle and do a lot more than what they can because they don't necessarily verbalize it. So in our assessment as child life specialists, seeing where they are so that we can identify what support they need. For instance, if a child is having a PICC line, I want to say he was 14 years old. He needed to have a PICC line placed. And I can see the fear in his face. And the questions that he would ask me let me know that he was nervous. Although his family was like, oh, it's something a 7-year-old can do. You can do it. But he didn't think that he could. And I advocated for him, if you need extra support to have this done, it's about you. It's not about your parent. It's not about your doctor. It's about what you need. And helping children to find their voice, especially the teenagers, find their voice about what they need to get through challenging times in the hospital. Sibling support, which has been really challenging during COVID because siblings are not allowed in the hospital right now. They haven't been allowed in since pre-COVID. So we've moved to doing virtual sibling visits, which is not always easy because getting children involved after they've been online for school throughout the day, it's like, they're kind of good. But the way that we did that was, I would send home an activity with the parents, and we would do art online before we even talked about anything, and build that relationship so that way that child and I can connect, and that child will feel comfortable having a conversation about their brother or sister that's in the hospital. Another thing we do is special events, holidays, birthdays. We had a mom who got engaged in the hospital, and her husband couldn't afford to have a wedding. So what I did was I called some connections that I had, and we decorated the room like we put like fake flowers all over the room. We put like a little mat on the floor, and we decorated the room so that they get married in the room, because they didn't want to not get married without their daughter. And she was having treatment at that time. So me and some of donors that I worked with, we decorated the room so that they can have their wedding in the room, and they had a spot to take a picture, and it didn't look like a hospital room. So those are some things, because it's all about creating normalcy, not only just for the patients, but for the parents as well. And then also connection to community services like camps and Kids Wish Network, and other like Coach Art, which is an organization that provides lessons for children that can't necessarily go to big crowds. So they'll come to their house and do music lessons, or they'll have like an art activity, whatever it is the kids want to learn. So in helping children cope, one of the first things that I like to do is have them identify their feelings. A lot of times children know angry, sad, and happy, but they don't know like when they're feeling lonely or they're jealous or they're embarrassed or they're happy or they're enraged, which is much more than being angry. So this provides an opportunity for children to identify those feelings. What I do with a lot of the kids that get diagnosed with chronic illnesses, whether it's cancer or an immune deficiency, I use this to help them identify the feelings. And then I jump into this right here, which is a feelings pie. And what I do is have them write all those feelings on this feeling pie, and then we talk about them. And we divide them up to what they feel the most to what they feel the least. And in that, we find ways, not only identify those feelings, but when we're feeling them, how can we jump to another feeling to take away only feeling exhausted or feeling angry? This kiddo right here was having chemo treatment, and he would be disgusted because of the vomit, and those things that people don't acknowledge that these children are feeling. As child life specialists, we give them an opportunity to express that so that we can work through it. Because if children don't work through the feelings that they have, they stay stuck and they aren't able to cope. So as child life specialists, yes, we do the play and we do the preparations and we do the understanding of being in the hospital, but also help address feelings. So what's really nice about being a child life specialist is although we're not licensed, we are able to do a lot of therapeutic activities and provide types of therapy without being licensed. This right here was a care tag that I created with a teenager whose parents were helicopter parents. And she felt like she couldn't go anywhere or do anything because her parents were constantly on her. She was dealing with a chronic illness, which means that it wasn't going away. So it was something she needed to express to her parents. So what we did, we sat and I asked her to write down, how does she need to be cared for by her parents? And she wrote these down and she said, sometimes I will ask for space, but after the fact, I will let you know what was bothering me. So she wanted some space to deal with whatever she was dealing with and then bring it to her parents. The other thing she said is, I promise that when I need something, I will let you know. For example, when I need food or drink, always asking me about my pain, they constantly focused on her illness and didn't focus on what she needed as a teen. And then after we did one for her mom and her dad, because they were separated, I said, okay, now we're going to share this with your parents. She was like, what? I was like, yes, you need to let your parents know this is what you need from them. This is how you need them to take care of you, because they had no idea. And their whole connection and communication as a family changed. And she was heard. As a child life specialist, you will be that connection between the parents, between the child, between the doctors, between the nurses, to make sure that children's voices are being heard. Because they don't have a lot of say. They can't say they don't want this medicine. They can't say I don't want this treatment. The parents make the decisions. Some children may have some inputs, but the ultimate decision lies on the parent. So how can I, as a child life specialist, help to navigate that so the children feel heard? And this is one of those ways. When we are doing their care needs and explaining procedures, using medical play, validating their feelings through some of those activities I showed you, explaining patients' role in their participation, helping children understand they have a voice. If they need a moment because it's overwhelming, let the staff know I need a break. If something is happening and they, like this little boy I had, he was 5. He got poked over 20 times in 2 days because they needed multiple labs. Well, he was over it. And he got so upset. He was so angry. He was hitting the bed. He was yelling. He was screaming. And they were trying to do a poke on him and hold him down. And I walked in the room and I was like, stop. We need to stop. And he needs a break. This is where advocacy comes in as a child life specialist, where you come in and you shut down the room so that way that child can have a moment to recompose themselves and get started again. And sometimes you have to meet children where they are. Oftentimes we want children to be where we want them to be. And as child life specialists, we help them get to where they need to be in order to have things done that they don't want to have done. These children don't want to be in the hospital. They don't want to continue to be coped. So helping them understand through different techniques that we use that I've discussed as like medical play, distraction, and helping them to be heard is really, really important. What our goal is as child life specialists is to help decrease fear. This is why we prepare children for what's happening. We educate children on what's happening, talking to them about their diagnosis and explaining what that is. Oftentimes, parents don't want to tell their children that they have cancer. They call it the C word, and they won't say the word cancer. I come in and I talk to the parents outside of the room and ask them, what does a child know? What have they learned? What has been happening? How are they dealing with being in the hospital? And parents will say, oh, they don't know. What happens when children don't know what's happening? They're not able to cope because they stay stuck in fear. All these doctors, all these nurses are coming into the room and telling them things that are going to happen, things that are going to go on. And so as child life specialists, we break it down for them and helping the parents understand the importance of telling the children so that they can cope and understanding that this may be the first time they hear a lot of these words in the hospital, like cancer, like you have to have a lumbar puncture, like you have to have an MRI or a CAT scan. This is the first time they've heard these. And so helping them understand what the language is really important. So when we talk to children about cancer, we explain it exactly what it is. You have this sickness in your body. It's called leukemia. Have you ever heard of that before? Most of them say no. Well, it's a really big word. And what that means is there's an infection in your blood. That sounds very different than, oh my gosh, you have cancer and you have to have this chemo. It's all about the way information is presented to children, how they're going to receive it. So we create memories for these kids when we're doing different activities, different supportive procedures. So that way, it's not just negative. Also, when we're doing grief and bereavement support, where we have to tell children about their brothers or sisters that have died. We use those words, dead and died. And it's difficult for parents to say that because of the fear that the way their child is going to respond. They're going to freak out. They don't want them to be sad. But just like us as adults have to have our moments of sadness, so do children. And children as young as infants grieve. They may not express it, but infants know that someone is gone. They know that their routines have changed. They know that something is different. The older children, 5 years old, they know that something is different and they have a concept of death, but not necessarily a full understanding. So what I do is explain that when your body dies, it's not doing its job anymore. You can't breathe, you can't run, you can't jump, you can't play. We find out what children like, what they're into, what they're engaged in, and bring that connection to the children so they understand death. Oftentimes, parents think that their children that are delayed won't understand. For instance, I had a 5-year-old and an 8-year-old, and they were both autistic boys. And the parents were like, oh, they're not going to understand, so we don't really need to tell them. I explained to them the importance of them hearing the words because they're going to see the reactions from everyone else. So I took these boys and we had playtime in a private room, and these boys were playing with their toys. And one of the boys says, my brother's sick. I said, you're right, your brother is sick. I said, do you know what happens when your body gets really sick and there's no more medicines that will help? He says, you die. I said, you're right, you die. I said, you know what that means? And he couldn't really explain it. And then the other little one was talking about killing his toys. So he's playing with his toys, like, I'm going to kill this person, I'm going to kill that person. And I said, well, what does that mean when you kill someone? And he says, well, you die. I said, well, what happens when you die? So I had to explain to them, but using their words and their language helps them to understand what I'm telling them, and telling them that when you can't play with your toys when your body dies. You can't run with your friends when your body dies. So that way they can really understand the concept. There is you do have to have multiple conversations with children when they're younger about death, because they bring it's repeat, it's more conversation. So what we do as child life specialists is help the parents prepare them for what's to come. If you have a 3-year-old, you're gonna have to talk to that 3-year-old at 3, 4, 5, 6, and have different conversations because their cognitive understanding changes as well. Creating memories with children that have lost someone. We do like memory boxes, or we'll do handprints for children. We'll make bracelets. I often give siblings little lanterns to light at their bed for when they're missing their brother or sisters. It's a little battery operated lantern, and they can turn that on and feel more connected. Also helping parents and staff know that silence is okay. We don't always have to say something to make someone feel better. And that's a very big misconception, that we as adults feel like we need to say something. We need to make someone feel better. And that's not always the case. So it's okay to be quiet in moments like that. And as child life specialists, you will learn when to talk, when not to talk, when to provide comfort and when not to. And it's also really important to be culturally have an understanding of cultural differences, because everyone reacts to death different. Everyone reacts to illness different. And also having understanding that loss doesn't always mean death. Loss is also associated with being diagnosed with an illness. Being in the hospital, period, can be a type of loss. So death is not the only type of loss that families experience while they're in the hospital.
Thank you so much, Misty. Before you move on to the next slide, I wanted to ask if you wouldn't mind pausing. There's a few questions in the chat. I've been kind of jotting them down, and some of them I think are tied really closely to what you were just talking about. And then maybe later I'll ask some of the earlier questions. So some of you who asked earlier questions, just know that I did see your question. I have it. I'm just going to start with a couple of questions that are more pertaining to the most recent slides.
Okay.
So we talked about something that's obviously really, really difficult, but it's a big part of your role as a child life specialist, and that's talking about death. So a couple of questions that students asked around that. One question was, does it become traumatic at some point for you as the liaison in this role?
Well, let me come out of here just so that way. As a child life specialist, you have to maintain boundaries. Boundaries are really, really important. So I explain it like this. There's a wall. You get this close to the wall, because you have to make connections with families in order to build trust. But once you go over that wall, that's where it's difficult to come back, because now you've become emotionally involved. There's a level of emotional involvement, but there's also a level where you have to stop that. Otherwise, you will not have longevity in this field. I see working with children and families during death and bereavement as an honor. And I feel so privileged to be in there at that moment, because it's one of the most vulnerable experiences that families may have. And losing a child, I can't even fathom the magnitude of that. You have to have a level of compartmentalization, because if you don't, you will take all of this and you will absorb it, and you cannot do that. You have to find your release. You have to find your coping as a child life specialist. So when I leave work, I leave work. From transferring from work to home in my commute, that's my depression release time, basically. And once I'm home, that's it. If I've had a difficult day, I'll tell my husband I had a difficult day and I just don't want to talk. And I am very strong in my faith, which is a big help for me, because I truly believe that God has placed me in this role and has given me this gift to be able to help others. So you really have to just separate.
Thank you so much. And there's another question kind of related to that. So do you generalize the explanation of death, not taking into consideration the family's religion?
Always take into consideration the family's religion, because you have to know how to explain to the children what's coming next. Not everyone believes in heaven. Not everyone has funerals or burials. Not all the children are engaged or involved. So it's really important to understand what the family's beliefs are. And if they don't want to, it's been rare that I haven't had anyone not want me to talk to their children about death and what that is. but it's really important to talk to the parents before you even talk to the children, because you need to know what you're going to explain to these children and helping them to understand, because they're going to have questions. Like if you tell them about, heaven, you have to explain what that means and what that is like. So when I have children that say, my brother or sister's going to heaven, I'm like, oh, well, what is heaven like? So it's asking a lot of open-ended questions to get their answers and their response, and not me giving them information. So that way I can clear up any misconceptions and help navigate their understanding.
Awesome. One more question that I'll ask for this segment. Someone asked, do you also give parent advice as to how to approach the child's reaction?
One thing we do not do is advice, because that, it's a real fine line when you're telling parents about parenting their children. I give suggestions and I explain what they may see in not talking to their children, talking to their children too much. I will help them understand what children's reactions may be in experiencing the hospital. As a child life specialist, you have to be really honest. Oftentimes the staff you don't ever want to take away anyone's hope in anything that they experience when they're in the hospital, but you also want to maintain a level of honesty so that they have an idea of what may happen or what may come. Families will ask me questions about what I think about some things. I say, well, you know your child best. You know what's going to work best for your child and how your child is going to react. There's difficult decisions that parents have to make sometimes, and they don't want to do that alone, but I can't do that with them. I can only give them the tools and the understanding to help them to make that decision.
Thank you. Thank you so much for responding to those questions, Misty. I'll pose a couple more later.
What I'll do is I'll stop after each, and then if there's any questions, we can. Sound good?
Perfect. Perfect. Thank you.
Yeah, let me share my screen. All right. Let me. Oh, I don't know if it's going to go back to where we were. No, sorry, I have to go all the way through because the way this presentation is. I'm so sorry. Here, let me.
No worries.
Yeah, it's one of those. I thought I was doing real cool with the Spanish. It won't let you go back to where. Sorry.
No worries. It'll help refresh our memory of what we've covered so far. It's already been so much great information.
And I'll go a little. I'm trying to get through that one. Okay, so let's jump into communication. Communication is really, really important because parents will hold on to your words. Children will hold on to your words. So if you tell a child that something's going to happen, it better happen. If you tell a child, oh, okay, I'll be back in an hour, you better be back in an hour, because they hold you to that. And that also is a big component of building relationships. This is also being part of a multidisciplinary team, meaning you're working with social workers, you're working with doctors, you're working with nurses, you're working with chaplains, you're working with dietitians, physical therapists. You work with everyone as a child life specialist in order to communicate what children's needs are. So when we're dealing with patients and working directly with them, we want to provide age-appropriate language, meeting children where they are developmentally. And the language is really important. For instance, when I said CAT scan, not all children know what a CAT scan is. So using that, some of them might think a cat's going to come and get them, right? Or shot. A lot of people say, oh, we're going to give you a shot. You don't know what children's backgrounds are or experiences. And shot can be like death, or I'm going to get shot with a gun, or what are you going to shoot me with? Some nurses say stick. We're going to stick you, meaning they're going to give them a poke, which is what we use because it's less threatening, but it's also honest. When they say they're going to stick you, what are you sticking me with? Don't stick me. I don't like being stuck. And that induces fear. So language is really, really important to help reduce that fear. Open-ended questions, like I had previously mentioned, that allows us to get the information and not give it. When I go and meet a child for the first time, I know what's going on, but the information that I've gathered by talking to the nurses lets me know what questions to ask. For instance, if I'm going to meet a child for the first time, I'll say hi, I'll introduce myself, and I'm like, can you tell me why you're here at the hospital? If they say they don't know, that lets me know the parents haven't been honest. If they tell me another reason they may say they won't know is because they're scared. So there's many reasons. And I say, well, I'll start asking them about the materials that's on their bodies, and we'll talk about that, and then we'll jump back in. But again, asking open-ended questions. Simple, concrete explanations are really, really important because so much big words and language gets used in the hospital that even parents don't understand. When you tell a child, oh, you have diabetes, most of them don't know what that is. What does that mean? Someone's going to beat me? They don't understand that. So helping them break it down and understanding what that is and explaining diabetes and what that does to your body. And the other consideration is when children come in and they've had experiences from family members that have been sick, now they already have in their mind that this is going to happen to me. That's where it's important for us as child life specialists to clear up misconceptions and answer their questions. If a patient asks me if they're going to die, and they have asked me that, I will tell them, that's a really good question, but no one knows when you're going to die except who. And they'll tell me God. And I say, you're right. So even if the doctors say they may have a certain amount of time to live, I try to change that and spin it so it's softer language for that child and can help reduce that fear. Or if they're going to have surgery, and a big fear of teenagers is not waking up. So they'll ask me, am I going to wake up in the operating room? A lot of them think they're going to wake up mid-surgery. So I'll explain to them, they give your body enough medicine to help you sleep so that your body doesn't wake up until the surgery is all done. Now, is there a possibility they can die? Yeah, there is a possibility that we can all die. But do I want to tell children that? No, because I'm not trying to increase their fear. And when I hear other people say that, I have to clear it up for them. So when I take children to go have a surgery and I'm with them, I will stand next to them and distract from what the doctors and nurses are saying, because they have to tell the parents all the possibilities of what can happen. And without me being there distracting them, they hear that. So I try to keep them away from that conversation in the conversation that we're having. For parents, we want them to be honest with their children. I've had many parents tell their children they're not coming to the hospital for tests and procedures. They're coming to go to the cafeteria. And then they end up in the ICU for a procedure. So then now I have to help them understand why they're here. And now that parent has lost trust, and helping to rebuild the trust with the parent as well. Helping parents also understand that it's okay to cry. Parents think that they have to be strong and I can't cry in front of my child, which is really, really hard to do when you're in that room and you're seeing what's happening and hearing the information that's happening. So helping parents understand, it's just important to put words to tears. Why are you crying? Because whether you cry in a room or you cry outside, they know. They see it on your face. So it's important to explain that. And as child life specialists, we help parents do that. Limit medical terminology, because parents don't really know how much information to share or what to share, what not to share. So helping them understand how to use child-friendly language and soft language. And then also maintaining boundaries and limits. Like I had said previously, parents want to give their children everything, and they stop parenting their children because they're sick. And that's where the focus turns on the sickness and not the child. So I will tell parents, like, the same discipline you had prior to your child being sick is the same discipline that they need, because I've seen children whose parents just let them do whatever because they're sick, and they can't reel them back in. Or they'll buy them everything, and then they've reached a max where they can't buy them anything else. I had one child who had Crohn's disease, and she had a very difficult course. And every time she came to the hospital, her parents would buy her something when she would go home. Every time she had a procedure, she would get something new. It got to the point where they bought her a $3,000 dog. And I said, well, now what are you guys going to do? When you develop relationships with families, like I can be very honest with a lot of the families and let them know, like, this is what you're going to see happen here if you continue to go down this path. And sometimes parents need that because, again, they start to see their sick child instead of their child. I encourage staff and parents to speak outside of the room. Oftentimes, staff will come and talk over children's beds. Doctors talk over their beds even if they're sleeping. One thing for sure is when children in the hospital, they act like they're sleeping, so you don't touch them. They act like they're sleeping, so you don't ask them any questions, especially the teenagers, but they hear everything. Imagine you're in a space that's unfamiliar. You wake up when you hear unfamiliar noises. So a door open, a different sound, so do children. I explain the importance of talking outside, getting the information, coming back, bringing it to the child. So that way, also parents can have their moments of emotional outbursts instead of having it in front of a child, because controlled tears are much more readily received from children than uncontrolled tears. And uncontrolled tears meaning like that convulsion, and like that's when they think something's really wrong. But also telling the child why they're stepping outside the room so they don't think something's wrong. And always address the patient. When I enter a room, I don't even talk to the parents. I talk to the child first. Hi, who do you have here with you? And that gives them a sense of control. Children have no control in the hospital. We're coming in their rooms, we're doing these procedures. So we want to try and give them as much control as we possibly can. Any questions?
So there weren't any questions in particular for that section, but I'll just pose a couple of the earlier, more general questions. One student was wondering, are the child life
You froze, I didn't hear it.
Oh, okay. One person was wondering, are the hours of a child life specialist the same as a nurse's hours?
No. It depends on what hospital you work in, to be honest. I should say that, because some hospitals do work on 312s. Some hospitals work on 410s. More children's hospitals, because at a children's hospital, you'll see like 30 child life specialists, because you have child life specialists for each different diagnosis and each different unit. So they work oftentimes 24 hours, because you have an emergency department, especially at a trauma center. They have 24-hour coverage in the emergency department. In other areas, it's typically 7:30 to 4 or 11 to 8. Typically, the latest time a child life specialist works is 8 o'clock, unless you're in the emergency department, because it's 24-hour coverage.
Thank you so much. One more question. I think you might have covered this earlier, but do you deal with grief and bereavement outside of the hospital setting?
Families would like me to. I often have families like, can we come back and see you, or can you come to our house, or but there are alternate settings that child life specialists work, like in hospice. There are some in long-term care facilities, and there are some in also a setting that is like I don't know. I have a friend, she's a child life specialist. She works in a setting where it is for moms recovering from alcohol. And so she works with their children, helping to reunify. So child life specialists are getting more broad in this areas that we work. But grief and bereavement outside of the hospital, only if you're within another organization, but not something that I do. I am short-term support for families. Although families that I've connected with, I will give them my work email or my work phone. And if they have any challenges along the line, whether it's giving children medications or they need some additional support, I have definitely done that.
That's wonderful. Thank you for sharing that. We have a question from Andrea. You want to go ahead and ask your question?
Yes. What I wanted to ask you, I asked that last question. I'm sorry, I'm trying to get rid of the reactions. Can I ask you a question or kind of present a scenario I'm dealing with now?
Yeah, absolutely.
With bereavement? Okay. I have a kindergartner who frequently, and I mean fairly frequently, tells me about his grandfather that died. He doesn't really give any details, but it just kind of seems like he doesn't have the opportunity to ever really say it. So I'm the next best thing. So he kind of brings it up, and I kind of just let him talk about his grandfather as much as he wants to. But I don't know where to go with that, because I could tell that he's looking for something more.
Yeah.
Do you know what I mean?
Yes. Because it sounds like he's not being supported at home as far as like having an honest conversation of what that is and what that looks like. What I would suggest is you go on Amazon and look at there's books. There's really good books for children, and you can incorporate this in your class as well, about death and from a child's perspective. I will give you a book. I will send it to Marini and give us your email, and I'll give you some suggestions for a book. That would be the best place to start for him, to have that in your class. The other thing is have him draw a picture of his favorite memory of his grandpa, you know, or something that him and his grandpa like to do. And when he is talking to you, the best thing is to just listen and not try and solve.
Okay.
Because that's the first thing we want to do, is try and solve it and make it better. But that won't make it better. And he just needs an outlet.
Okay.
There's also a really good book called When Terrible Things Happen. It's an activity book.
Okay.
That's super helpful.
Thank you so much.
You're welcome.
I'll send you my email right now, Marie.
Sure, yeah, absolutely. And if it's okay with Misty, we can share, someone had asked earlier about sharing your presentation slides, if those would be available.
Yeah, I can send that.
Okay.
I think you have it. Don't you have it, Marini?
I do. I just wanted to make sure it was okay. And I probably shouldn't be asking in front of everybody and putting you on the spot just in case you're like, it's my property. Sorry.
No, it's fine.
Awesome. Okay, so I put it in the chat, a couple of books. So Misty mentioned When Terrible Things Happen. I recommended The Invisible String. And then someone else mentioned Life is Like the Wind. But look out for your emails for other resources that we can share later. One other question before we move on that someone asked. Let me go back to it. Who and how can a family request a child life service rep? Like under what circumstances? Who can request it, and how can you request it?
Any circumstance. So anytime your child steps into a hospital, ask for child life. Even if you're going, like for instance, Kaiser, which is a pediatric floor in an adult hospital. Not everyone in the hospital knows about child life because our focus is pediatrics. Unless you've had an experience or exposure with child life, you're not going to know that they're there in that type of setting. So if you're in a adult facility, most hospitals that have pediatrics has a child life specialist, at least one, if not part-time, one per diem. And if they don't, then that's where maybe they can connect you with a child life specialist at a different hospital so that you can get some suggestions. There are also some books out there about child life. Actually, childlife.org is a good resource if you aren't familiar with child life or you're looking for different information that can help. There's also this book, I have it here in my library. It's called The Precious Ones. This little book, you probably can't see it because of the whiteout, but it's called The Precious One, that talks about children's experiences in the hospital. But there have been a lot of child life specialists that have wrote books to help parents prepare to go to the hospital. You can also reach out to a children's hospital, CHLA, UCLA, Irvine, or Long Beach, and they can give you some resources as well to prepare you to take your child to the doctor or to prepare your child for some experience with the hospital.
Thank you so much. There's a few more questions, but I'll save those for the next segment.
So advocacy, and I'm almost done with this presentation, and then you can ask me all the questions you want.
Perfect. Thank you.
When advocating for children, it's really, really important to understand that age is nothing but a number. And oftentimes doctors and nurses look at children's ages and think they can do a lot more than they can, and they cannot, even at 17 years old. I had a teenage boy who needed to have a lumbar puncture and a bone marrow. A lumbar puncture is a procedure that collects spinal fluid to test for any type of leukemia cells or any other type of cancer cells. It's used for other test diagnostics as well. And a bone marrow is used typically for diagnosis of a cancer. And this young man had a type of mediastinal mass, which is located here in the chest, so we couldn't sedate him for his bone marrow. And a bone marrow is very, very painful. In front of his parents and his uncle, he was saying to me, I'm good, I'm fine. I said, okay, do you have any questions? No, I don't have any questions. But his face told me everything. And his uncle was like, he's a man. He doesn't need to know anything that's going on. He's just going to do it. And I was like, all right, well, and I turned to the patient and I was like, well, if you have any questions, you let me know. He was like twiddling with his thumbs, picking at his skin. All of those nonverbal cues were telling me how nervous he was. Well, when his parents and his uncle weren't around, he started crying. And he tells me, he says, why is this happening to me? I'm a good kid. Why is Jesus punishing me? I didn't do anything wrong. All I want to do is help people. So I helped him navigate and understand that Jesus is not punishing him. Sometimes we're giving different challenges to help us to grow or to learn. But what we want to do is find out what's happening in their body. And this is how we have to do it. And I helped him through that procedure. And he did really, really well, which was great. But just acknowledging those feelings and allowing him the space to have those feelings. I didn't tell his family about his tears because I didn't want to take away his feeling of being a man in front of his family. So we kept that with us. And I didn't want to lose the trust with him either or make him feel any less than. So it's something to really remember working with children and teens. Not all children are going to cooperate. They're not going to all lay out their arms and let you poke them or do things to them. So we have to guide them to a place where they will allow us to do these things. Certain children at a certain age, you can't hold them down. You can't make them do things. Children, you can't make them take medicine because what do? Spit it out. We have to want them to do these things, want them to help their bodies and look for self-gratification and not for external gratification. And as child life specialists, that's what we do. Allow them to express their thoughts and feelings, however that may be. Some parents get really embarrassed when their children, or not their children, I should say, that the teenagers start using inappropriate language. As long as they're not directing it at me and they're directing it at the situation, they need to express themselves. And sometimes that happens. So helping the parents understand that this is important for them to express themselves. Validate and reassurance is really, really important because of the fear. And validating those feelings and reassuring them that this is for this moment and letting them know that the next moment will be different and the next moment after that will be different. And language, we've talked about how important language is. So these are some things that kiddos say. Are my stitches going to open? When children get up for the first time having spinal fusions, their biggest fear is if they move, their stitches are going to open up. But they're not going to open. It feels like they're moving. Instead of saying pulling, I say that they're moving. Because if I say pulling, that's a trigger word for children, right? It's a fearful word. Are they really going to put me to sleep like my dog? A lot of doctors and nurses say, oh, we're going to use this medicine. It's going to put you to sleep. It's anesthesia. A softer way to say that is we're going to give some medicine to help your body sleep for the time that you have your surgery or your procedure. And when you're all done, the doctor will stop giving you medicine and your body will wake up. Will I become addicted to pain medication? This is a fear of parents and it's a fear of teens. I had this one teenager, her dad was addicted to propofol and he overdosed on propofol. So she didn't want to have propofol for her procedure. I had to let her know that they're only going to give you just enough to help your body sleep. And it's a controlled environment. It's not like out in the streets and using this type of medication. I'm too dizzy, I can't get up. Children will make up any reason, rhyme, or excuse not to get out of bed or do things that they need to do. And parents will allow it because children scream, they cry, they yell. So helping them to get through those feelings and understand that, yes, it's going to hurt. But if you don't move, it will hurt more. And I tell you that patients tell me when they get up and start moving, they feel so much better. That's where that reassurance comes in. Will I get sick from swallowing dye? So dye is how they explain contrast to children. You're going to get this dye, and this dye is going to help light up your body. Okay, well, I'm going to dye in their eyes. So helping them understand that it's a color that they use to help see the inside of your body better instead of dye. Am I going to die? I've talked to you about how I help children understand that. Parents will be like, no, you're not going to die. You're going to be fine. But in the child's eye, they're not going to be fine. So just reassuring them why we're giving them the medicines, why we're doing the tests that we're doing, why we have to be here at the hospital. That's what they need. They need to know the why. Why do they keep taking my blood? I need it. I had a little 5-year-old who was newly diagnosed diabetic, and she had to have repeat blood tests for her to check her blood sugars. And she didn't understand because no one told her. And she said, stop taking my blood. I need my blood. So I had to help her understand how her body continues to make blood. And you will always have enough blood because our body makes it more and more. So helping her understand that. And again, will I wake up when I have anesthesia, and helping children know that they don't wake up until the procedure's all done. Oftentimes when people think that they wake up, that's usually the time where their body's starting to wake up, but it's not fully awake, but you think that you're awake and they're still doing stuff to you, but that's not the case.
So I'm going to pause just for 1 second. I don't know if that was the end of your presentation.
Just this last little quote.
Perfect.
That's it. So what we want to do is a child is like a piece of paper on which a person leaves their mark. So as professionals working with children, what kind of mark do we want to leave on children? And how do we want to make an impact in their lives?
What a beautiful, beautiful quote.
Thank you.
Thank you so much. And I'm so impressed that there are still 97 people on this at 8 o'clock, 8:01. This was perfect timing. So I know that technically our time is up at 8, but I'm gonna ask Misty if she wouldn't mind staying on just for a few more minutes to answer some of the questions that folks have. And those of you who need to jump off, thank you so much for being here. We really appreciate you giving us your evening time. We know it's very valuable time. And those of you who'd like to stay on, we invite you to stay on for a few minutes. You might have another question, or you might hear the answer to a question that you had. There are some really great questions in the chat. Some students, I know you mentioned this earlier, so while I go through now, I'm going to scroll back because now everyone's saying, thank you, this was amazing. So I got to go find some of the previous questions, but there were a few questions in there about the requirements to be a child life specialist. I think you touched on those in the beginning, but if you can just kind of reiterate, master's degree, what is required to be a child life specialist? And then while you're answering that, someone else had asked if you work with art therapists, and I'll look up the other questions.
So to be a child life specialist, you have to have a bachelor's degree in either child development, psychology, or a related field. If sometimes people think that they're a teacher and they can come and be a child life specialist, yes, you can, although you're going to have to do an internship. An internship is what establishes you as a child life specialist, okay? You can't jump in and say, okay, I'm coming from teacher, now I want to be a child life specialist. Let me apply for this job. You need an internship. That is where you learn to be a child life specialist. After your internship, you can get a job, although you will be required to be certified within 1 year. So there's a certification exam that child life specialists sit for. It's usually a 3.5 hour exam, and that's where you get certified. And that is a national recognized certification. And then if you want to grow in the field of child life, you will need to get a master's. It's not required, but in order to go from raise yourself in a clinical ladder or become a supervisor or be in management, you need a master's degree. Now there is.
Glad you clarified that, because I was putting in the chat, you need a master's degree. So my mistake, I am incorrect in that. You don't need one, as Misty said, but it is helpful to move up in the field.
It is. And then there are master's programs in child life. If you are jumping from one career and making child life a second career, it would be recommended to go and get a master's, because you're going to learn a lot of very important information like family systems, preparation. You get all that you need to know about child life. Now, in that, if you get a master's in child life, know that that's all that you will be able to do is child life, as opposed to getting a master's, like, for instance, I have a master's in human behavior. So I can do a lot more with that as opposed to only child life. Now, that is an avenue that you can go, and a lot of people do. But if you're thinking of being a child life specialist, it's really important to kind of think of that now when you're in undergrad or going into a program, because then you have more options as far as doing your internship.
That's super helpful. Renee had asked if a child is having mental health challenges, do they qualify to see a child life specialist?
Those are my favorite. So not everyone has the ability to work with children with mental health, and it's becoming more and more profound than it ever has been before. And it's a very unknown environment for pediatrics, period, because most children that are dealing with mental health, they're either in the ED and they get transferred out. Not many are coming to the pediatric floors. So that has been changing. Yes, it does constitute a child life specialist intervention, but it really, you have to monitor what your role is in that, because not crossing over boundaries and maintaining your role, which can be very much intertwined with social work, very much intertwined with psychiatry and psychologists. So the way that I work with mental health is maintaining their safety, helping families, staff know how to approach and not try to change. Because people always try to change behavior. We need to navigate the behavior, right? And when you're dealing with mental health, you have to meet them where they are. Again, that's psychologically, not chronologically. And that's what a lot of people that work with children is try to deal with, the chronologic and not the psychologic, right? So when you have a broad perspective and understanding of different populations, then you can jump into working with all types of children. That you get that experience from your continued education. My interest has always been mental health. So I look for opportunities to go learn more about mental health through social work conferences, through mental health conferences, working with children that are autistic, going to the autism conferences. So you broaden your scope and your understanding, and then you can connect. And also learning about behavior modification, because that's really important when you're working with children with mental health in the hospitals, behavior modification.
So helpful. I'm going to combine a couple questions. Students were asking about internships, or how can you volunteer maybe to learn more about the field and maybe kind of informally and volunteer in a hospital setting?
Childlife.org is a really good resource to start. If you are interested, definitely volunteer at the hospitals. They're opening up again because we were closed for a while. And going and volunteering at a child life program, because then you'll be placed in the playrooms and you'll see kind of what child life does, and not necessarily one-on-one, but you will be able to see what it's like to be in a hospital, and if that's something that you can even emotionally do, because it is an emotional toll. I honestly don't think about what I do until I start talking about it to people that don't know. And then I start to get a little emotional, and I'm like, wow, I do that every day. And so that's where it's important to be able to separate, but definitely volunteer at a child life program.
Thank you. I put the link in the chat for childlife.org. Go with the second one. The first one, I accidentally put a little apostrophe there, so that one will not take you to the correct place. So I think those are most of the questions. I'm going to just open it up if I did get to your question because it got lost in there somehow, or I thought it was answered and maybe you didn't quite feel it was answered, I'm just going to open it up for the next maybe 2 to 3, 5 minutes. If there's another question, I'm going to just ask students here. You can raise your hand or you can unmute and just go ahead and ask your question. Go ahead, Andrea. Oh, that was an applause, not a hand raise.
It was an accident. I'm horrible at this.
Oh, no. Thank
Right,
you.
Misty. My question is, I really personally, as a teacher, I do know that I need some training with some sort of kind of grief counseling. It's impossible to teach, period, without having it, because kids' parents literally get shot in their faces, crazy stuff where I'm at. And so what I wanted to ask you is, do they have any like 6-month certificate programs or something? Do you know what I mean?
Yeah,
You know
I
how
do.
they have those type of training things? Do you
Yeah.
know of anything like that?
I do not. You either
Okay.
have to go through the whole program, but there are some hospitals that offer, like, not hospitals, I'm sorry. There are some schools, like Cal State LA offers a class of like children in the hospital, there is the Doogie Center is a great resource to gather more information about dealing with bereavement.
Okay.
It's so important, and you bring up a really good point that anyone that works with children needs to have a grief and bereavement class. We're actually trying to incorporate the nursing program into our grief and bereavement class because I teach a grief and bereavement class, and social workers, psychologists, psychiatrists don't know how to necessarily work directly with children. They have more of a broader spectrum, but when you work with children, it's a completely different approach. But try the Doogie Center, which is a good resource.
Okay, thank you so much.
You're welcome.
Is that DOOGIE Center?
DOUGY.
Okay, DOUGY. I'll put it in the chat.
I have a question.
Yes.
I wanted to know, do you work with art therapists?
I don't work directly with them, but they are a part of child life programs, art and music therapy. And if when I worked at Children's, because I didn't have art therapy at Kaiser, but if I have a child that needs to have a little bit more of an opportunity to express and needs a little guidance with the expression through art, that's when art would get involved. But art therapy definitely is, and also art therapy is in hospice.
Thank you. This has been really good.
Good, I'm so glad. I love talking about child life.
I love it. So I just put in the chat the link to the Doogie Center. It's called the Doogie Center for Bereavement Grief Support. I'm not saying it right, but because I lost the page, but
Thank you, Rini.
yes. All right, so I think we're done. Are there any other pressing questions before we bid you adieu for the evening? And you will get access to the recording as well as the slides.
I've got to say, Misty, we have learned two things specifically. Number one, we have to have a session at every Teach for LA on becoming a child life specialist. And the other thing that is shocking to all of the producers of the conference, we have never run a 7 to 8 p.m. session like this. I think a couple years ago, we maybe did like one student panel a little bit earlier, but not usually this late. And so thank you for inspiring over 100 people to come out this late in the evening. And from now on, we'll probably be adding some extra like later sessions because it looks like it worked for people. So this was fantastic. Oh my gosh.
Thank you.
Yes.
It's an amazing, amazing career choice. I mean, you will not be dissatisfied, that's for sure. And there's the only thing to consider though is you have to be willing to relocate because there's not a lot of hospitals in California, but there is a lot of opportunity for child life. It's just California has such a small hospital selection, and typically child life, I would say the turnaround is about 5 years. Most people stay in child life 5 to 8 years because they have families or they decide to do something different. But for those of us that have been in for the 18 plus, it's awesome times 10.
It's super helpful. Thank you so much. Now you all understand why I said I have to bring Misty when she was able to share in person with my students. And I had students coming up to me saying, oh my gosh, I didn't know about this career. I want to do this. So I'm so glad, and we're recording, so that's even more beautiful, so we can continue to share this knowledge. So thank you, everyone. We really appreciate it. We'll be in touch soon with the resources from this presentation, and have a wonderful, wonderful evening. And thank you, Renee, for putting this together. Renee is the real MVP because she's the backbone of this whole operation. So, and you always do it with so much poise and grace, and I just really appreciate it.
Thank you, Marini. I live and breathe and eat it for a couple weeks here. In my life, so I appreciate it so much. Thank you. I love it.
Awesome.
We just need to keep doing it, right, everybody?
Yes. Thank you so much, everyone. Good night.
Thank you. Good night.
Good night. Thank you.
Bye, everyone.